Welcome to this Basic Life Support learning package. This package will briefly touch upon Pediatric Basic Life Support and then continue on to Adult Basic Life Support, following the new Australian and New Zealand Resuscitation Council guidelines. At the end of this tutorial, you should be able to identify the process of basic life support using the Australian and New Zealand Resuscitation Council's flowchart. Identify indications and correct technique for CPR. Identify correct airway maneuvers used in basic life support. And identify the procedure for applying an automated external defibrillator. In child and infant basic life support, it is important to know the classification of what is a child and what is an infant. An infant is defined as being younger than 1 year of age. A child is defined as being between 1 to 8 years of age. Children older than 8 years of age should be managed the same as adults. Some special considerations are: an infant's head should be kept in the neutral position for delivering rescue breaths, while a child's head should be kept in the head tilt, chin lift position. Rescue breathing may be done effectively using an appropriately sized children's mask or by using an adult-sized mask that is turned upside down. Ensure that the mask fits firmly on the face to achieve an adequate seal while delivering rescue breaths. The method of delivering compressions to an infant differs from that of a child. For an infant, you should locate the center of the chest and use 2 fingers to deliver the compressions. Cardiac compressions and rescue breaths are performed at the same ratio as that of an adult, that is, 30 compressions to 2 breaths. For children up to the age of 8 years of age, the heel of one hand only should be placed on the center of the chest. Compressions for infants and children should be commenced at the same rate as an adult, compressing the chest by 1/3 of its depth on each compression. This table summarizes the appropriate CPR technique that should be used for the infant, child, and older child. For information regarding the use of defibrillation with children and infants, refer to your local policy. Cardiopulmonary resuscitation is the technique of chest compressions combined with rescue breathing. The purpose of cardiopulmonary resuscitation is to temporarily maintain a circulation sufficient to preserve brain function until specialized treatment is available. Rescuers must start CPR if the victim is unresponsive and not breathing normally. Even if the victim takes occasional gasps, rescuers should begin CPR. The Adult Basic Life Support Algorithm of DRS ABCD describes the initial steps of resuscitation. The algorithm stands for check for danger, check for a response, send for help, open the airway, check for breathing, begin compressions followed by 2 rescue breaths, attach an automated external defibrillator if available and follow its prompts. Your first responsibility is to protect yourself from danger. Once you are assured of your own safety, the next step is to protect the victim from any further danger. This requires you to remove any actual or potential hazards from the area. You should consider the use of personal protective equipment such as gowns and gloves to enhance your protection against being exposed to body fluids. Assess the collapse victim's response to verbal and tactile stimuli, ensuring that this does not aggravate any actual or potential injuries. Give a simple command such as "open your eyes" or "squeeze my hand and let it go." You should then grasp and squeeze a shoulder firmly to try and elicit a response. A person who fails to respond should be managed as if they are unconscious. A person who shows only minor response to stimuli, such as groaning without eye opening, should also be treated as if they were unconscious. The mouth should be opened and turned slightly downward, allowing the removal of any obvious foreign material such as food, vomit, blood, and secretions to drain using gravity. Loose dentures should be removed, but well-fitting ones can be left in place. Visible material can only be removed by the rescuer's fingers. Under no circumstances should the rescuer attempt to remove obstructions or material they cannot see using a blind finger sweep of the mouth. All unconscious victims should be handled gently with no twisting or bending of the spinal column and the neck. If it is necessary, move the head gently to obtain a clear airway. If available, use suction to clear debris. In unresponsive adults, it is reasonable to open the airway using the head tilt, chin lift maneuver. To perform this, one hand is placed on the forehead or on top of the head. The other hand is used to provide the chin lift. The head, not the neck, is tilted backwards. It is important to avoid using excessive force, especially when a neck injury is suspected. The chin lift is performed by holding the chin using the thumb and fingers to pull the chin upwards and open the mouth. This action moves the tongue and the soft tissues away from the back of the throat, opening the airway. The jaw thrust is an alternative maneuver to the head tilt, chin lift. Using this technique, the mandible is brought forward, relieving obstruction that can be caused by the soft palate and epiglottis. To perform the jaw thrust, the rescuer should place their index to little finger behind the angle of the mandible. Upward pressure is then applied to move the jaw upwards and forwards. Using the thumbs, the mouth is opened slightly by a downward displacement of the chin. The jaw thrust is the preferred option for a victim with a suspected or actual spinal fracture. The use of oropharyngeal and nasopharyngeal airways should be limited to those who have had training in their use. Incorrect use of these devices can further compromise a victim's airway. There is a high incidence of abnormal gasping after cardiac arrest. Lay rescuers and healthcare professionals should use a combination of unresponsiveness and absent or abnormal breathing to identify the need for resuscitation. The rescuer should look for movement of the upper abdomen or lower chest, listen for the escape of air from the nose and mouth, and feel for the movement of the chest and upper abdomen. These observations should be performed for 10 seconds. If the victim is unresponsive and not breathing normally after the airway has been opened and cleared, the rescuer must immediately begin 30 chest compressions before giving 2 rescue breaths. The palpation of a pulse is unreliable and should not be performed to confirm the need for resuscitation. Once the combination of unresponsiveness and not breathing normally is confirmed, chest compression should begin without delay. To perform compressions, rescuers should place the heel of their hand at the center of the chest, with the other hand on top. Compressions below the level of the center of the chest should be avoided, as they may cause regurgitation, while compressions delivered above the center of the chest are ineffective at compressing the heart. The center of the chest should be depressed by 1/3 with each compression. Rescuers should perform chest compressions at a rate of 100 a minute. While performing CPR, you should keep the arms straight and deliver compressions directly over the sternum. If able, change the person delivering compressions every 2 minutes to prevent rescuer fatigue and deterioration in the chest compression quality. When changing, this should be done as quickly as possible to minimize no blood flow time. The 2 rescue breaths are given after the delivery of 30 chest compressions. Mouth-to-mask resuscitation is a method of rescue breathing which avoids mouth-to-mouth contact. Rescuers should take appropriate safety precautions when feasible and when resources are available to do so. If you are using a mask during resuscitation, if able, position yourself at the victim's head. Use both hands to hold the mask in place and open the airway using the head tilt or jaw thrust maneuver. Deliver the breath with enough volume and force to observe the chest rise, then remove your mouth from the mask to allow for exhalation. If the chest does not rise, recheck the head tilt, chin lift, or jaw thrust position and the mask seal. Failure to maintain the head tilt, chin lift, or the jaw thrust is the most common cause of obstruction during resuscitation. You should aim to give each breath over 1 second, allowing the chest to fully recoil before the next breath is given. Rescue breathing has an oxygen concentration of around 16%, compared to the atmosphere's 21%. If able, provide supplemental oxygen as quickly as possible at high flow rates. If rescuers are unwilling or unable to do rescue breathing, they should perform chest compressions only. If chest compressions only are given, they should be at a continuous rate of approximately 100 a minute. Any attempt at resuscitation is better than no attempt. The importance of defibrillation has been well established as part of overall resuscitation. An automated external defibrillator should only be used on a victim who is unresponsive and not breathing normally. Cardiopulmonary resuscitation should continue while the AED is turned on and the defibrillation pads attached. The rescuer should then follow the prompts given from the device. The time to defibrillation is a key factor that influences survival. Every minute that defibrillation is delayed, there is a 10% reduction in survival if the victim is in a cardiac arrest due to ventricular fibrillation. The development of automated external defibrillators has made defibrillation part of basic life support, as they can accurately identify cardiac rhythms as shockable or non-shockable. Place pads on the exposed chest in the anterior lateral position. All pads have a diagram on the packaging showing the correct placement of each of the pads on the chest. Pad to skin contact is important for successful defibrillation. There may be a need to remove moisture or excessive chest hair if the defibrillation pads are unable to obtain good skin contact. This should be done quickly to avoid delaying possible defibrillation of the victim. The adhesive pads should be rolled onto the victim's skin to avoid trapping air bubbles and possible arcing of electricity and burns from the shocks delivered to the victim. The anterior pad should be placed to the right of the upper sternum, with the upper edge of the pad below the clavicle. The lateral pad should be placed below the left nipple, with the center of the pad in the mid-axillar line. For women with large breasts, the pad can be placed underneath the breast. CPR should not be stopped while the defibrillation pads are being attached. If a shock is required, order stand clear. Do not press the shock button until all personnel are clear of the victim. It is the AED's operator's responsibility to ensure safe delivery of the shock. If a shock is not advised, CPR should be resumed immediately. The AED will prompt to continue CPR whether or not a shock is delivered to the victim. Each cycle of 30 compressions to 2 breaths should be performed 5 times. When complete, if attached, allow the AED to reassess the rhythm. The rescuers should continue until the victim responds or begins breathing normally, it is impossible to continue, a healthcare professional arrives and takes over CPR, or a healthcare professional directs that CPR be ceased. It is important to maintain safety while using an AED. All free-flowing oxygen should be moved away by at least 1 meter from the victim during the delivery of a shock. If the bed or floor is wet, ensure that no one is in contact with these areas during defibrillation. You should not place the defibrillation pads over metal jewelry, as this could cause arcing of electricity on the victim's skin. If possible, avoid placing the defibrillation pads over any implanted devices, placing the pads at least 8 centimeters away from the device. You should never defibrillate a conscious patient. Also, you should avoid placing the defibrillation pads over anything that will reduce pad-to-skin contact. Some examples include ECG electrodes and medication patches. If the chest wall is wet, such as after a shower, dry the skin first before attaching the defibrillation pads.
Hello, Mr. Smith. How are you today? Mr. Smith? Mr. Smith, are you okay? Mr. Smith? Can I get a hand, please?
You right? I'll call the arrest and grab the AED. Yes, hello. Can I place an arrest call, please? Ward 1, bed 1. Thank you. Okay, I've called the arrest. They're on their way.
Tear open package and remove pad. Tear open package and remove pad.
Okay.
Tear open package and remove pad. Peel one pad on. Peel second pad and place on bare lower chest. Do not touch patient.
Okay, do not touch
Analyzing
patient.
rhythm.
Stand clear, everybody.
Do not touch patient. Analyzing rhythm.
Okay.
Shock advised.
Okay, shocking.
Charging.
Stand clear, everybody. Stand clear, shocking.
Shock delivered.
Okay, continue compressions.
It is now safe to touch the patient. Start CPR.